but we'll wait for more people to come in. I've already recorded this, so the video will go into Dr. Intan punya. But I'll ask her again. I'll just say students haven't got their videos yet. Okay, I'll just let her know. Where are you all? College ke? Sewa rumah ke?
Sewa,
College
Doktor.
class.
So you're happy to be back or very sad to be back? Apalah soalan Dr. Khor ni? Happy or
Happy.
sad? Why happy?
Happy. Because we want to meet Doctor.
And then, but I think face to face is better lah. Online is !aiyo! Online like that lah. There's no face to face. Then you see your friends back. Then you sit in lecture class. Then you see next door your friend is asleep because it's already lunchtime. Okay. How many? 65. Okay. What did I want to do? I want to. Okay, I don't remember what I want to do. What I wanted to do, I want to share. Okay, what I wanted to share, PowerPoint. Okay, share. Okay. Let's see if this works. I want to know whether you all can listen to the YouTube. Ada suara ke? Ada suara ke? Did you all hear anything?
No, Doctor.
What you say? Sorry.
Tak dengar
Tak
apa-apa,
dengar
Doktor.
apa-apa kan?
Tak.
Okay. So I stop sharing. I have to. Okay. Webex change already. Kepada. Okay. Motion video share. Kalau macam ini.
Or EKG.
Korang
And we'll see
dengar
it's
ke?
got a P,
Yes,
Q.
Doctor.
Okay, great. All right. So now you all see this slide?
Yes.
Okay. Okay, so what we're gonna do for the first 30 minutes or so, kira kita bersantai sekejap lah ha. Everybody sudah makan kan, perut pun dah kenyang kan, itu kepala feels so heavy. So we're just gonna watch some YouTubes, but practically this YouTube is just to refresh back some memory, or either when you come in for your rota later on, if you see that machine, we will hook it on and we will demonstrate also as well. Or maybe when you go for surgery that time, you're definitely going to see this patient monitor being placed on for surgery. So at least you tak kalut atau sesat atau masa masuk, it's like, oh, the machine, and then totally don't know what to do with it. Then the machine monitor puts picture like this, then you don't know what is it. So that's what we're going to do lah. Okay. Then after that, we go into ECG. We'll look at Oscar punya trace. And that's when the time all of you will start crying and then complaining. Doktor, tak nampak kotak. Doktor ini, doktor itu. So the idea is memang macam itu realitinya. Tapi you don't have to give me a exact estimation of the boxes or second. It's okay. I will show you why that is okay. But as long as you know the idea how to calculate and read the PQRST complex and then find out what's the duration, knowing what's the heart rate, itu pun sudah memadai and cukup. And after that, you go and look at all the abnormal traces, look at the question, look at the abnormal traces, and then pick up what does this abnormal traces means. Okay, so we will discuss about it lah. All right, then the fun part comes in pula. For videos, I'll be showing you all types of coughing. I have compilation of my patient. Some of them are in heaven, some of them are still alive. So I know you will have videos of this lecture. Sharing is caring, but you don't share my material, please, to people outside, because let's say it goes up on social media or whatnot, and then some of these cases has already passed away, and client confidentiality is very important. So the only way is I still need to share you all, but you all promise once you got the video, you use it just for your panggil apa? Just for your own learning purposes. Okay? Don't share it outside. Please don't share on social medias and stuff like that. Then people see, oh my god, that's my dog. And why my dog face is viral, so they might come after me lah. Okay? Can I, student? Okay, so let's learn about how the first one was just now. So I go I don't like this webex. The first one was just now. What should I be doing? Okay, this one. This one. Okay, never mind.
Get vaccine-related information on
And
Google.
listen, so
Don't work
just
for money.
flashback
Make
again.
it work for you. Robert Kiyosaki. Robert Kiyosaki once said, don't work for money.
Now let's think about the normal ECG trace again. What I've already drawn myself here is an isoelectric line. And we want to use this to consider the ECG or EKG. And we'll see it's got a P, Q, R, S and a T wave. Now ECG stands for electrocardiogram, as indeed does EKG. So in the States there's a tendency to refer to EKG. In the UK we would call it a ECG, but it's exactly the same thing. The K actually comes from the German for cardio, because I think these machines were invented in Germany, and also the K is consistent with the original Greek as well. So whichever you call it is fine. Now I often get asked about the PQRST. They don't stand for anything. They have no meaning. They're completely arbitrary letters that are assigned to these different waves. That's all it is. There's nothing significant about that. So we start off on the isoelectric line. Now ISO means the same. So here we don't have any significant electrical activity. But then we get electrical activity in the form of the P wave. Now the P wave goes up and it goes down. So all of that in green is the P wave. The bit that goes up and the bit that goes down. And as we see, it goes back down to the isoelectric line, just here. Now what's happening here with the P wave is the P wave is caused by the depolarization of the atrial myocardium. So in the myocardium, there's lots of individual cardiac cells, lots of individual myocytes. And at rest, these are going to be negative inside, about 90 millivolts negativity. So there's more negative ions inside the cell than outside the cell. And when it's at rest like that, we'll say that that is polarized. So that is the polarized cell. But then when it depolarizes, that's all going to change. So when it depolarizes, it changes to become positive on the inside and negative on the outside. So here it was negative inside and positive outside. The depolarized position is the opposite. That is depolarized. And it'll actually depolarize to about plus 20 inside. For a period of time, then it'll be about plus 10. But what we see is it's polarized there and it's depolarized there. And the important thing about this is that it's the change from being polarized to being depolarized that initiates the muscle contraction. That's what triggers the initial muscle contraction. So the muscle's sitting there in a polarized state, then it depolarizes, and that's what stimulates the contraction. Now, that's the P wave. The next thing that's going to happen is there's going to be a Q wave, and that goes down and goes back up to the isoelectric line. So that is the Q wave in yellow. And again, we see it consists of a downward deflection and an upward deflection. And then it's the P wave that carries on as the large upward deflection, which is the R wave, up and back down to the isoelectric line. So everything in red is the R wave. And then after that, this line actually carries on below the isoelectric line and then goes back up to it. So it's P, Q, R, so that's the S wave there. And again, we notice the S wave has got this downward deflection followed by an upward deflection. And then we have a little more isoelectric line here. And then we have the final wave. Well, we normally count it as the final wave, which is the T. The T wave. So P, Q, R, S and T. And again, we notice the T wave is the upward deflection and the downward deflection. That's what counts as the T wave. And then we have some more isoelectric line prior to the next P wave. Now, we've said it's the depolarization of the muscle that causes the contraction. So this depolarization here is going to stimulate atrial contraction, and that's going to go from about there to about there. So this period of time here, from the P wave to about the middle of the QRS, is when the muscular contraction of the myocardium, the atrial myocardium, generated by the depolarization of the atrial myocardium, is taking place. So that's the depolarization. That's the time when the contraction takes place. And when the muscle is contracting, we call that systole. So this is the period of time of atrial systole. Now, the QRS complex is the depolarization of the ventricular myocardium. And the depolarization of the ventricular myocardium will initiate the contraction of the ventricular myocardium, which will take place during this period of time here. So first we have atrial systole, and then the contraction of the ventricular myocardium, ventricular systole. And all that muscle contraction is stimulated by the depolarization. But of course, in order to contract, the individual myocytes need to depolarize. But of course, they can only depolarize when they're in a polarized state. This can't depolarize again because it's already depolarized. So if we want another muscle contraction, and we most certainly do, another 0.8 of a second or so, can you see this has to go back? The depolarized has to become polarized again. It has to change from being positive on the inside back to being negative on the inside. And that process is called repolarization. Because only when it repolarizes does it become polarized again, because it can only initiate contraction when it changes from being polarized to being depolarized. So we're now in a position where we can have another cardiac contraction. So P in green, Q, R, S and T, all in their relevant colours. And what confuses a lot of people is that the wave is the upward deflection and the downward deflection, or here the downward deflection and the upward deflection, away from this isoelectric line, iso just meaning the same. Now we often talk about a sinus rhythm, and a sinus rhythm is generated by the sinoatrial node, the pacemaker of the heart. And a sinus rhythm has got a P, Q, R, S, T in the right order and is fairly regular. If there's a P, Q, R, S, T in the right order and it's fairly regular, but the rate is below 60, that is a sinus bradycardia. It's still initiated by the sinoatrial node, it's still fine, but it's below the rate of 60, so technically it's described as a bradycardia. If you've got a P, Q, R, S, T in the right order and it's fairly regular, but the rate is above 100, that is a sinus tachycardia. They're the three normal rhythms: sinus bradycardia, sinus rhythm, sinus tachycardia. And this is what we've drawn actually here is a cardiac cycle. So the atrial systole takes about 0.1 of a second, and the ventricular systole takes about 0.3 of a second. If we assume the whole cardiac cycle is about 0.8 of a second, as it would be if the heart rate was around about 74 beats per minute, which would be fairly normal. So we see that the P wave in health can be considered to be the same as the atrial contraction. We know it's not quite the same because the atrial systole actually comes a little bit after. And we can consider the QRS to be the same as ventricular contraction. We know it's not quite the same because it occurs a little bit after. But in health, the depolarization will always trigger the contraction. There's only one exception, and it's not in health, it's by no means in health, but there's a very dangerous cardiac arrest rhythm, and it's called pulseless electrical activity. And in pulseless electrical activity, you get this electrical activity in the heart, but it's not associated with any contractions. The muscle is depolarizing, but the myocardium is unable to respond kinetically because of severe problems such as exsanguating hemorrhage. That would be the only exception, pulseless electrical activity. Apart from that, P is atrial, QRS is ventricular, and T is repolarization of the ventricle. Now, we've said that the T is the repolarization of the ventricle, the ventricular myocardium, which we see here, the repolarization. So P is depolarization, QRS is depolarization, T is the only one that's repolarization. So obviously, we're going to need a repolarization of the atrial myocardium, but we don't see that. Well, that's because there's so much electrical activity going on in the QRS that the repolarization of the atrial myocardium, which of course takes place, it has to take place, but we don't see it because it's buried in the QRS complex. But there will be one, there has to be, otherwise the atrial myocardium couldn't depolarize to generate the next atrial systole. Now with practice, these ECG readings can tell us all sorts of things. We can do positional ones called 12-lead ECGs. They'll tell us about the normal conducting pathways. They'll tell us about heart damage. They'll tell us if the heart is enlarged. And they can also tell us what's causing myocardial pain. So well worth learning the basic PQRST. And then with experience, you'll realise that this has lots of implications for pathology, patient assessment, and patient management.
All right, so that's your basic, right? During your physiology. Who teach you all physiology for cardiovascular?
Prof. Go.
So he would have already touched about all this as well lah. So I think you have already left that, information for about a year or two. may have not remember what is repolarization and depolarization. So that's just a little bit on the nutshell lah, of what you should remember. So that video is done. Let's move on to the next one. The next one shows you how to use an ECG machine. How do you set them up? Okay.
Hey guys, David List here.
Do you all want the
We
image
are
to be
going
bigger?
to do a quick ECG tutorial. Really quickly, the first part of this video is
Can you
going
all
to be about
hear?
how to place the leads correctly, and then another future video will be on how to really rapidly interpret an ECG. So this is going to be a monitor that's got 3 different leads. Some of the monitors have a 4th lead that's technically a ground lead. That's actually not required, and it's typically green. So if there's a green one, it basically goes on whatever limb you don't have any other leads on. And the nice thing is that these are labeled. The white one is the RA for right arm. The black one says LA for left arm, and the red one says LL for left leg. These are actually pretty standard. So a really easy way to remember these is that white on right, all right, so we'll go ahead and apply some alcohol and put a clip here. All right, kiddo, good girl. Clip number 1. Now, black is going to go in the front with the white, so just remember that the black one's going to go there, so we'll add some alcohol there. This goes there. And now, the way I remember this is I don't remember smoke over fire, Christmas, or I can't figure out what comes when. So I just remember red, not white. The white one's up here, right, on the top, the right upper limb. So this is going to be the left rear limb. So we're going to put it back here.
So what he's saying is that all that black, the red, and the green, he mentioned all those 3 colors, isn't it? So for me, you actually don't have to remember which color goes to which leg, because it depends on whether the machine comes from US or UK, or depending on the manufacturer, they will tell you. Some of these leads, they are color coded as in like brown, white, and different colors also as well. But these are the normal colors, like it's always green, red, black. Or either sometimes you can see brown, or sometimes you can see white leads. But for me, you don't have to remember about which color goes to which leg. So you just have to go according to the manufacturer of the machine. And then there will be always a small booklet that tells you which lead goes is supposed to be for what. Okay, so don't really have to be worrying about Christmas or what after red or
So
after black.
again, white, right, front right. Black goes with white, so that's the left arm, and the red one lives in the back, red not white, and that's how we set up an ECG light.
Okay, so that's a very short one. Any question? Any questions so far? So for normally, let's say if you want to attach the leads, you don't have to shave. No shaving is actually required. And then all you need is some gel to increase contact, or alcohol is already sufficient. Sometimes water is also fine, because alcohol will easily dry up, but actually nobody will do ECG for a long period of time unless you're doing monitoring. So that's about it lah. And clipping on ECG to a cat or dog is actually non-painful. When you purchase this kind of machine, you just have to ensure that the lead that you're using, they looks like a caliper. Okay, so they look like a caliper. Then all that you need to do is just wet that particular area. All right. So let's say this is the dog. This is the dog body. This is the foreleg, and this is the dog body. So when you want to attach your clip or whatsoever, all you need to do is just wet this particular area and then just clip it on. All right. And that particular clip normally are not supposed to be traumatic, as in like when you clip it on, and after that you will cause some wound over there or whatnot. By right, it shouldn't be that way lah. Okay. Any questions so far? So, no, then we watch the next video.
Hey everybody, David Liss RVT here, and we're going to look really quickly at how to kind of rapidly interpret an ECG. So we have a live ECG going here, and we're going to see all of these complexes, 1, 2, 3, 4, 5, all the way down, complex, complex, complex. So let's take a quick look at what we're seeing. This little wave right at the beginning is going to be the P wave, right? So P wave, P wave, P wave, P wave, okay? This next part that goes up and down is the QRS complex. So let's follow them. QRS, 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 all the way down, all right? And this very last little part, this upstroke, 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 that's the T wave, all right? So we have a T wave, T wave, T wave, T wave, T wave, T wave, all right? So when we look at this, and then also we have this calculated heart rate. Now, the way that these machines calculate these heart rates is based on the R waves, so they're not always totally accurate. They can double count complexes or be inaccurate. So you always want to try to print a strip if you really need to calculate the heart rate or check a pulse, depending on if there isn't, an abnormality that would change your pulse rate. So if we're looking at this, you can see that this patient does have a little bit of an abnormality. This patient has a pretty normal sinus arrhythmia. So how do we see that? Well, there's some complexes here that are similar distance, and then look at that space here, similar distance space, okay? This is kind of an irregularly irregular rhythm. So normal, normal, normal space, pause, normal, pause, pause, normal, normal, pause, normal, pause. It's all over the place. And this has to do with his breathing. So when she breathes, there's some spacing that happens in that ECG. But the P wave connects to the QRS wave. There's always a QRS wave for every P wave. Okay, that's really important. There's also a P wave for every QRS wave, and our rate is relatively normal. So we have a decently normal sinus arrhythmia here, nothing too crazy. Now, some of the other things that can happen is that your settings on your ECG can be off. So the first thing is a lot of these machines have different leads. So now we're looking at a lead 3. That looks a lot different, doesn't it? What about a lead 1? That's also going to look different. It's a little similar, but we're losing that intensity of the P wave, and we get a lot of interference. Okay, so we're back to our lead 2. That's the most commonly interpreted ECG lead. The other thing that you can mess with is the gain. The gain really has to do with the amplitude of your complexes. So here's a gain times 4. That's really hard to interpret. I don't know what's going on here. I don't know what the spacing looked like. So let's look at a gain of 0.25. Oops, that stayed at 4. Oh, nope, it did. Sorry. Go back out. Look at that. I can't really see much other. Now the machine goes, I can't see anything. What's going on? It's too small. So we can adjust that gain to something that looks really nice, clean, and able to be interpreted. Okay? The other thing is this machine happens to have a filter, so you can change the filters around and see what best works. Now see, there's already some interference that it's picking up on the dia filter and the MON filter. There's also some interference that's not very diagnostic, but if I change it to the surface filter, now we have a much nicer ECG.
Okay. Okay, students. So the video, if you all want to, David Liss has got a few of the other couple videos that you all could go up and see. In fact, the one the other one also he used to draw a lot of stuff. But basically YouTube just give you a lot of all those little things that you might want to see. For example, this one. There are a few that you can actually just search and look around lah. But otherwise, when you come back for your rota, then we can also do this also
Howdy,
as well.
and welcome to a how-to video on canine and equine.
Let me see, this one has got what? Okay.
I have a very cute canine volunteer for the canine ECG and a horse model for the equine ECG. When running an ECG, make sure you are familiar with the system you are using and what additional items you may need. The one we are working with today requires the use of gel and electrodes, while others may require alcohol or nothing at all.
So this one just use gel.
The patient is placed in right lateral recumbency, and the electrodes are placed on the elbows and knees. The electrodes are color-coded and go to a specific area on the canine. The white lead
that's
is
how
the
they
right
attach
arm, the black lead is the left arm, and the red lead is the left leg.
And don't
A
worry
good way
about
to
the
remember
colors.
this is white is always right for the right arm, and smoke over fire for the black and red electrodes on the left arm and leg. If the electrodes are not set up correctly, your ECG will look odd, such as the QRS complex will be upside down.
Okay, so some of the machine, you just print it off. And normally all these paper traces are very small ones, so they will just give you lead 2 information. Okay, they won't give you all the 6 leads. Tak nampak. Okay, there you go.
When doing an ECG on a horse, there are a couple of differences from the canine ECG. The horse will be standing, and the setup and placement of the electrodes is different. It is important to remember where to put the electrodes. To remember the electrode setup for the horse ECG, I like to think red goes with blood, so it must be on the jugular. And white and withers both start with W, so the white electrode goes on the withers. Then you're left with the black electrode, and that one goes on the heart. Now we will hit the highlights on how you read the ECG printout. The first wave is known as the P wave and represents the atria depolarization or contracting. Depolarization is initiated by electrical impulses from the sinoatrial node. The atria contract and fill the ventricles with blood. The next segment following the P wave is known as the QRS complex and represents the contraction of the ventricles. After the SA node simulates the atria to contract, the depolarization wave continues to the AB node, which sends an electrical impulse down the ventricles, causing both to contract. The last component is the T wave, and this represents the ventricles repolarizing, in which they relax, getting ready for the next depolarization wave.
So, okay. Any questions, students? Hey, you're so quiet. I don't know whether you guys are around or not. Any question? Okay. No, let's go to ECG and calculation. You want to break down to your groups. Maybe we'll meet back at what? Now it's 2:30. We'll meet back at 3:10 like that. Okay, but I'll be around here. You want to create your own link within your group, go ahead. But I'll just open up this link just in case if you have got question, you just come back to this link and I'll be here. Okay?
Okay, Doctor.
Okay, Doctor.
Have fun.